So if you can't hear me, let me know. So I think we can all agree that it's so exciting that we are in the first year of really spending these settlement dollars. And the state has several different opportunities. I mean, they want to get that funding out the door to you all so that you can spend it in your communities. And I think one really special part about the funding is that you can tailor it to fit the needs of your community. With the infrastructure share, we have gone through one round of funding, and we have recipients that are out there spending that money. And it's really exciting. Congressman Lasky, she was one of the recipients of the first round, and we just finished selection of the second round, which will be announced tomorrow by the Attorney General and COAC. The infrastructure share is really exciting for parts of Colorado that are more rural, underserved, that don't have that infrastructure established to support the work that you want to do to address the opioid crisis. So when you're thinking of applying for funding from the infrastructure share, and I would encourage you to, because there will be 2 rounds every year of funding for that. So every 6 months we're going to have another round where we're accepting applications. Start thinking about what can happen in your community to support the programs and the projects that would make an impact in your area, that would maximize those dollars. That's really the intent of the infrastructure share. We have approximately $2.5 million to give out every cycle, so there is money that is going out the door. And then there's other ways that we're looking to utilize the opioid settlement dollars. For example, from the state fund, we have the innovation grant that we just launched, and the application period has closed. We're in the middle of evaluation, so I can't say very much about it. But this is a funding opportunity of about $4 million. And it is looking for innovative, thinking outside the box ideas on how you want to address the opioid crisis in your area. So these are just 2 ways that we are looking to really get that money out the door. And I would just encourage you, if you have any questions, to give us a call at the DOL. We're representing COAC, and we would love to chat with you about some of your ideas, or if you have questions about the funding opportunities. But most importantly, I think Jack probably already said it, there's a newsletter that we send out where every funding opportunity that is approved, you'll be the first to know. Any questions? Jack? Seth?
I think that's great. So okay. Yeah, I think it's a nice transition to.
I have a quick question.
Yep.
How many innovation grant cycles will there be, and is that every year?
Yeah, well, that is a really great question. So this was the first that we launched, and it was undetermined if we were going to have a second. Can't say much because it's a competed process and we're in the middle of it, but there was an overwhelming response. Such a great idea. It's innovative ideas, thinking outside the box, like going to set the pace for some of, I think, some really high impact work that's going to be done in Colorado. And since the response was so great, I think we've already decided that we're going to have a second round. I don't know when that will be launched, but again, if you sign up for that newsletter, you will know as soon as we get it into the timeline and decide when applications are going to be accepted.
Are you able to give some examples yet about what some of those ideas were that you got?
For the innovation, I can't. It's a very, it's a competitive process, and right now I just can't say anything, but it was exciting. Any other questions? Okay, give me a call if you have any questions.
Salkin, over to you.
All right. Can y'all hear me? Awesome. My name is Steph Salkin. My pronouns are Shanya, or they, them. And I am the current project director for the State Opioid Response Grant that is housed within the Behavioral Health Administration. And so we're going to go over some of the funding considerations for the funds that go through us. I'm going to go over some current projects. Then I want to tease you with some SOR3 expansions. That's a little bit more of that, like, yes, come work with us. Let's see what we can do together. And hopefully leave you with a lot of links and resources. I have the tendency to do TMI slides so please don't be overwhelmed by the amount of text there is on here. This is publicly available, so please be in the moment with me and you will absolutely have access to these slides at a later point so you can get all of the links. Cool? All right. Why the BHA? We are the single state authority. We are the designated entity that gets a lot of the formula grants from SAMHSA. That's the substance use SABG. I try not to use the abuse word to be a little more trauma informed and less stigmatizing. But yes, that is how we get substance abuse block grants as well as mental health block grants. It's called formula grant because pretty much our representatives kind of carve out how much we'll get out of the budget, and then there's a formula that dictates how much each state and territory gets. So that's why I'm the one talking in front of you. But we do try and play nicely with other departments. But yeah, that's a little bit of that. So I wanted to break down SOR awards through the years. You can see that we've had, no, you probably can't see, this is blurry. So let me just talk you through it. The original SOR year one was about $15 million. These are 2-year grants. And then we also get the chance, if you can see a little bit, what we don't spend, we get another chance to spend in carryover. And then if we haven't spent all of that, we can go into no cost extension, which makes it into a very complicated waterfall effect, which is part of my job security, and why sometimes it's a lot of hurry up and wait, and also very short spending periods for us. So that's why sometimes people will give us really great ideas we wish we could run with, but unfortunately because of the time spans that we have, and of course the state processes, we're not always the best option for doing these types of projects. And then currently we are at over 21 million per year in the current year. That will end in September. So this timeline goes all the way out through the current one. So yeah, that's a little bit of that. So unlike state funding, at the end of the year, it doesn't go poof in the night. It doesn't get reverted, but we have to do a lot of paper pushing in order to get those second and third chances to spend it down. All right, and then also another major consideration is we are at the back of the line. All right, HCPF gets to go first. People are eligible for any payments through HCPF and Medicaid. We get behind that. Any state funding, we get behind that. So it makes it a little bit hard to get firm commitments, especially when we're in an awesome state where, you know, we actually put money toward recovery, not just treatment, etc. Yes, question?
Quick question. Are these put out as competitive RFPs, or how are these dollars distributed?
Yes, all of the above. It's actually, and I didn't include a pie chart, but the great majority of these funds go through the managed service organizations. That is not a competitive bid because they are, you know, legislated to be our partners and are in between, and then they will do many of the RFPs. And then for some of the other projects, for example, with the consortium, you know, we have different projects, which I'll go through a little bit, but each one will look different. All right, so this is an example. I call myself your friendly neighborhood bean counter because I do like to get granular like this, but just to maybe make it a little more concrete, this is what sometimes our invoices look like, in that you are capturing, that's some of the phrasing we use, capturing some of the other funding sources, and then you can tap into the SOR funding. So that hopefully also makes it clear that we are potentially that intermediary, that gap stop, something a little beyond the bare minimum that other funds may be able to support. All right, so a little TMI. You don't need to remember that, but I did want to give a sense of scale with some of the different BHA funding types. So this is $60 million across all of the substance use programs. I do believe that that includes state funding, some of those other 36 million within the last state fiscal year for those block grants that I mentioned. And that's just substance use, that's not the mental health. And then SOR, which is very targeted toward opioid and stimulant use response, that's about 21 million per year. Can fluctuate depending on our funders. And then some of our grant parameters, I'm not going to go over all of them, but we do require a lot more data collection. The four-letter word, that is GIPRA, yes, we do require that. I do apologize. That's one of the offsets of SOR funding, and why even if we aren't always the funding of last availability, if there's another funding, sometimes folks will opt to use that funding before ours so that they can avoid doing that GIPRA because it's long, it's tedious, and we don't hold that against folks. But that is the accountability tool that is used to show that we are actually achieving things with these funds. So at the end of the day, that's the super simplified count and metrics that they will show to our representatives, Congress, etc., and say, this is what they've been doing with all that money and why we should continue to keep funding that. Another one that I wanted to pull out is xylazine. On top of fentanyl, test strips are now within allowable. So Sophie will talk a little bit more about that stuff. I'll leave that there. And then one other thing that I wanted to point out, we do have a lot of disallowed items on our list. One I will touch on later is that we can do some minor alterations and repairs. All right, so we have a whole bunch of current SOR projects. I'm going to try and talk quickly. Let me know if it's too quickly, but again, you can have the slides. All right, so a lot of it is expanding access to treatment. With that, we do pay for, as I mentioned, anyone who makes too much money for Medicaid but is still under 300 times federal poverty level, we can pay for treatment, and that does get triggered when they have a current or history of opioid and or stimulant use. So please know that that is a targeted but somewhat wide net. We've also funded a number of mobile health units throughout the state. I do believe that the only SSPA that isn't touched by that at this point is just the Boulder area. It's kind of surrounded. But yeah, that is one way in which we've expanded access. And those have spun off to a number of pop-up services as well. So even when the units die, as they will eventually, there is a lot of service provision through pop-up services. Even though people do not have enough demand in some of these lower populated areas, we can still get services out there without having to sustain a whole brick and mortar practice. So that's one of the ways that we've tried to innovate that. And then we have the mobile opioid treatment programs. This is one that came out with the last grant. That is methadone on wheels. Now, that means that you have to get the sign off from the DEA to run these, which means that they have to stay very close to their home clinic, which means they're not as great of a tool for the rural regions because of that. They do have to go out and back to their home every night and off-board the meds. So that's why we've decided to centralize those around high census areas so that we are expanding access without needing potentially very costly real estate. So those are received, and they should be operating as soon as they have DEA approval, coming soon. All right, and then we have miscellaneous capacity building projects. I'm very happy that we are able to work with both of the tribal clinics, and what that looks like is more supporting FTEs to bring in OUD expertise into their existing clinic. Again, not a full FTE needed, but we can support them on a regular enough basis that they're expanding access to care for folks who are within that, yeah. That's pretty much it.
For number one, is that age restricted?
No, we have tried to reach out to folks. I would say age age limitation may be more about the provider and their scope, honestly, than our funding. Hopefully that. All right, even more. Okay, we also have been trying to increase the number of outpatient primary care providers who are not only, well, we're done with the data waiver at this point, but before we started, we worked hard to get as many people waived as possible. But even beyond that, we want them comfortable with prescribing. We want them trauma informed so that they can retain folks on, and this is usually buprenorphine or Vivitrol, not as tightly controlled. So there we have a little bit more of that hub and spoke. And then we also have a forum. These links, the yellow one, please share broadly. Share broadly. It's free. Anybody who has questions about treating folks, this is a free resource. We have amazing providers with a lot of experience on hand. And then also, again, residential treatment used to be more of a thing, not as much now that Medicaid's covering it, but we will still cover folks who are ineligible. And then that's a repeat, so I can go to the next one. All right, so also we want to build a lot of not just the skeleton and the musculature, but the fascia that really keeps us together, keeps us moving, keeps us in place. So connecting people to care is a huge part of what we do as well. And by we do, I mean we fund. Lots of other people do the work. I'm really just the paper pusher who tries to keep them funded so they can keep doing that. So recovery coaches, we have roughly 20 positions around the state with a variety of specialties. We also fund subject matter expertise at the crisis line. So please know that if you ever run into you or your system or your region, etc., please know that there are people at the crisis line 24/7 who would be able to refer folks to local resources, etc. They have a lot of those contact lists. Please use it. And then we try and help support the peer symposia to work on workforce. And then people in recovery. We've been so happy to see recovery community organizations get so much more funding. And so we're happy to support that to some degree. We're also really happy when other funding sources step up to the plate and say, we will fund this. And then we will step aside and again catch anyone who isn't eligible for that whenever possible. And then housing first and recovery residences. This can look like a couple of things. Whenever there isn't other funding, we try and get more houses available. And then also, and this is another one I really want people to take advantage of, we will help get people initiated into recovery housing. So we can help cover the first month rent, sometimes even that deposit, so that they aren't in a vulnerable place when they are fresh in their recovery, etc. So please take advantage of that. And then another one, it's been going as long as our grant, I believe, community reinforcement approach and family training. And this is for the support system, the natural supports, so that when somebody is experiencing, substance use disorder, we know that that can ripple through family units, community, etc. This is another resource. There are groups throughout the state, virtual, in person, in Spanish, English, etc. This is something folks can use for free, access for free, that'll give them skills to help support folks get into treatment or just reduce use, etc. So another one. And then we try and fight the stigma, as I mentioned, not just in our use of language, but also giving people concrete items that can help support, create connection and community, and just awareness. So we have media kits. Please feel free to share on social media. Okay, juicy bits, expansions. like I said, mobile opioid treatment programs. We've got 2 of these units in the denser areas. You can see that we have some lovely branding on the sides of them, and they are designed to be clearly identified as healthcare services without mentioning that it's behavioral health to avoid some of that stigma. And then medication units. Like I said, the mobile OTP programs are not great for remote areas. So our alternate innovation are medication units. So this is one that will be coming soon. There will be an RFP for it through the MSOs, so get friendly with your MSOs, and there are links to find them if you don't know off the top of your head. But this would be roughly $80,000 per location. We want these to be in areas that do not have an opioid treatment program in the area, so that they can be a satellite from an OTP. That means that you have shorter travel distances to folks. This can greatly improve quality of life if you do not have to drive as far to get your meds. But yes, we will do the startup costs for folks within areas to get these started. And since it doesn't require as much staffing, this is more like renting out a room in a clinic or something along those lines, and somebody who's able to do the dosing, but your prescriber, your therapist, etc., can be telemedicine. So that means it's cheaper to staff, and that should mean that it won't take as many patients to get solvent to support the actual practice. So that's just the beginning. We're starting with about 4 of these. That will be coming very soon. It should be in the 2nd year of our grant. So please keep your eyes open for this. Please start that communication with your regions to see how this might come together. And then,
excuse me, you just said something about, what did you say about 80,000?
Mm-hmm. $80,000 as the rough ballpark that I threw out there. Part of that is can be minor alterations and renovations, which is grant speak for not construction, but you can change out the door so it's more secure. You can install security cameras, anything that you would need to get a building up to date and up to code for licensure.
And so you guys are looking at 4 of those.
Mm-hmm.
In rural areas, urban areas, what's the criteria for that?
I think we've focused the mobile OTPs in the urban areas because that's a little more feasible. So these are much more for rural, remote, any underserved or historically excluded populations. If we don't get enough applications, we can definitely open up more in the Denver metro area. Yeah, good. I'm so glad to hear that. And right now the RFP isn't out, so I can talk about this, But yes, this is one of those things that we are very much looking forward to. It may be a little iffy in terms of what our DA officers say in terms of what the requirements will be, but I would say that expect a lot of what maintaining this. Talk with your OTP in your region, and they'll have a much better idea of what would go into that. But we do hope that people will think creatively about if you have hospital space that isn't being used, can this offset that in your area? Are there other clinical places? Yes.
I feel like I might know the answer to this question, but what does eligibility look like for who can actually apply to this? Could a region as an entity go after?
You will need to be an OTP.
Okay.
Yes, so I think it's completely fair, and I won't be running the RFP.
Yeah,
Oh, I am so sorry. An opioid treatment program is licensed to distribute controlled substance like methadone. So, that would greatly increase the availability of that medication for folks. So this would operate like a satellite from a full-fledged opioid treatment program. So even if you don't have one in your region, though, you may be able to partner with some of these folks, and they are searchable online, of course, as a treatment program. They are available through SAMHSA. Yes?
Quick question, just because you said MSOs, not everybody's gonna know what an MSO is, I do, but I just wanted to say that because the BHA is talking here, and the MSOs are the ones who are actually gonna be hosting the RFPs, or will it be on your site?
You don't want me to run that RFP, it will take forever.
You know,
So
I
we're
mean,
running
just
it
like
through.
look into it on your site so that people know where to go to get it, because I don't think, how many know what an MSO is? Raise your hand.
Good
So
call.
I have a feeling that
Good call.
So,
Managed Service Organization, MSO, that is pretty much an intermediary. We give them a fat bundle of bucks, and they then find credentialed providers appropriate to it throughout their assigned regions. And they do contracting, negotiating rates, et cetera. And so they're quite faster in putting out those
you list
RFPs.
them on your website, so if people wanted to find them, that's where
Absolutely. You stole my thunder. It's on the
Sorry.
last slide. No. Thank you for calling me out. If I speak in alphabet soup, please raise a hand and doink me. I will break it down. I'm sorry. Yes.
Can we use telehealth as the provider?
Yes. That's the intent. We really want this to be staffed. And usually you'll want maybe some security. You don't want just one person by themselves unless they're already within a secured facility. But yes, this is designed to be lower overhead costs. Hopefully somebody who lives in your area who has the ability to distribute the meds under a prescriber who can then be beamed in with telehealth from the home OTP.
Can the person that's with them be a pet dog, or, I mean, we don't have a lot of people.
Pretty sure the DEA will not sign off on that, but thank you. Yes, hi.
Great. I just want to offer, for example, because I know some of you had asked, recently, this is a complete example, but this is something that recently worked out in a slightly different manner with Denver Recovery. They're based out of Denver. They just recently opened an office here in Montrose. They opened an office in Glenwood. Those are their own self-standing organizations, but they are a hub that's in Denver. They may look to partner with someone that would open up a room in a medical clinic or office in another region. And there are other OTPs or methadone clinics across the state that might be interested in that as well. I just thought that might help to answer some of those questions that were asked earlier.
Thank you. Yeah.
There was an online question, so for everyone who are live streaming this, there was a question online that said, how would one go about getting funding for treatment for an individual who falls between the cracks due to not being insured through Medicaid, however is under the poverty level?
I'm going to hear that as over 300 times the federal poverty level.
Over the poverty level.
That I am not sure. There may be some pay scales. It really depends on the provider. We try and cover as much as possible, but yes, we are limited to that 300% poverty level. However, when somebody does trigger as eligible for this funding, we can cover all of their treatment around that, so it's not just the medications. Not great, but, and also services that aren't necessarily covered by other things, we can cover, and that I think looks different for different providers, but yeah, that's what we can offer.
Right here.
If I, just for that question, that person could reach out to different treatment agencies around them. Often they have access to a lot of different grants, MAT grants, signal grants, things like that, that will pay for their medications, their treatment. I know our agency has 3 or 4 different grants that will absolutely pay for treatment and medications for that person. So I would ask them to probably reach out to different agencies and ask about those options, whatever's nearest them.
Thank you, that's great. Again, another reason to bookmark the link to the MSOs is to also hit them up because they are braiding funding at that level as well. Apologies, I am specific to the state opioid response grant, so I may not be able to answer to all of the funding that comes through the BHA. But yeah, and there were questions over here.
I had a question, just so
grounds of the BHA grant recently that the portal closed like 4 days before the grant was due and we're not allowed to get in, and then another grant where it was closed maybe a month beforehand. Do you know what's going on when those are being closed early without warning and people were just before the deadline and then it's closed off? Do you know?
That sounds horrible. No, I personally do not. Like I said, I try and not run RFPs whenever possible because that will run the entirety of my grant cycle. And that's unreasonable for people to be able to actually spend the funding. So I do apologize. And I hope that there were support links within the same page.
There was no response and people tried to appeal and complain about it and it was dismissed. So I don't know. I'm just trying to figure out. We had no one to ask and nobody to explain themselves and it sounds like you don't know about it.
No, I do apologize. There are a number of RFPs that are running, that have been running.
So I think a lot of people might not apply for the grants given that
Our infrastructure is,
experiences happen. People,
yeah.
everyone I know is like, you're not even applying for the grants because it's really,
I hear you.
not sure if you know anything.
I don't. However, and this, I'm going to have a cheeky face because my office mate before COVID was tired of hearing me say this. Submit a ticket, submit a ticket. If possible, there is a contact address for the BHA, whenever possible, including screenshots. And then feel free to copy me. My email address is just steph.salkin. It should be pretty easy if you can just find the spelling of my name on here. But feel free to copy me, and I will do my best. Not the wizard who can solve everything, but at the very least, I can be one more human from this side of it, trying to find answers. I'm really sorry y'all experienced that. That does not sound equitable. But yeah, thank you. Yes.
This is another online question coming in. It's their understanding that regional councils cannot apply for grants because they are not legal entities and it is not within the scope of the MOU. True or not?
So I'm sorry, I'm a bean counter, so I go immediately to the technicality that as an entity under CDHS, we are unable to sign MOUs. I would say, though, one way around that is to create a cooperative and find a partner with whom you can co-apply. So it really depends on which RFP, which funding source. There are technicalities and there's no one answer for all of these. But for example, for the med units, this should be headed by a currently licensed OTP, but if it is an application that is submitted with the support of the region, and if they have some of that it's being submitted as collaborative, et cetera, that is one way that you can potentially access the funding. How that looks in the books afterward would have to be negotiated. But sorry, that was not quite an answer. But if you're looking for other funding types, definitely look within the phrasing within each RFP to see who is the eligible entity for applying to these. Some of them are harm reduction agencies, some of them are specific to treatment programs, and some of them are specific for communities. When in doubt, call our procurement team or the name on there, and we will try and answer those questions. It can be tricky around RFP time, though. Did that answer?
It's somebody that's zooming in, and I'm kind of filtering those questions.
Thank you. All right, Zoom people, you heard my email address. If I'm wrong, you can hit me up. Yes, another. There is a,
I was
yeah.
just going to add to that, just to help clarify. ROACs probably cannot apply for this. However, that's where it's really important for the ROAC leaders to be working with the people within their communities who are doing this work on the ground and making sure that people outside of the county commissioners and municipal and county folks that this falls on their shoulders of, that they're working with the community members who are doing the work on the ground so that then they are connected to the people who have the licenses to be able to provide the medications and services. So it's really something that we at the consortium strongly encourage, that you have that integrated group of both voting and non-voting members that includes people doing the work across the board, both in recovery, treatment, prevention, harm reduction, criminal justice, and then that way you're able to identify those opportunities and identify those people and organizations in your communities that can apply for these and fill the gap that you're identifying as the roadmap.
And another plug for the infrastructure share, which Robin helps manage, is that regional opioid abatement councils can apply for that. There just has to be a fiscal entity as the sponsor. And so we can answer questions about that, but infrastructure share is a great way to apply.
Any other questions about med units? Yes, these can be one way that jails can get methadone delivered. Yeah.
Yeah, that was actually my question. I was wondering if under expanding accessible NAP programs, if the BHA was looking to also expand NAP programs in the city and county jails, because I know right now a lot of times they just continue NAP but don't induct new people on NAP. Is that something that the BHA would consider doing as well?
Yes, so I will have to put in a little caveat that that is more within the jail-based behavioral health services team, JBBS. So we have in the past funneled funding through them because they already have the agreements in place. But yes, usually that will look like we will help with standing up a program, getting the medications in place. Usually the hardest part is getting the provider and the services there. So case-by-case basis, but theoretically, yes, that is absolutely within scope for our grant. So if it isn't covered by JBBS funds, that may be something that we can work on with folks. Nothing I say is a legally binding contract, so. All right, and then another thing I'm interested or very excited about are putting out some more content for folks. Should be free. We're also trying to get some grad students in to help pass on some of the evidence-based practices that will help folks not just get into treatment, but also in long-term recovery. And then we're also supporting DOC in expanding their peer training program. So another way we would like to innovate with you is think about employing some of the peers who graduate out of that. People with intersectional lived experience are a wealth. They are amazing and would be a great boon to any recovery community, throwing that out there. And then CRA, Community Reinforcement Approach. This is one of the EBPs that we are supporting. We're putting together training materials, contingency management. Unfortunately, we're still capped at $75 per person per year. It's not evidence-based. I'm pissed. Anyway, everybody I think is pissed about this. We keep pushing SAMHSA, so fingers crossed. In the meantime, what we're gonna focus on is getting the educational materials so that folks are prepared for SAMHSA funding when they increase that max, or that capitation. All right, ways to get more involved. There are other SAMHSA grants that do not come through your single state authorities. So please, have a watch out. That's another newsletter I would encourage you to look for. Again, sometimes that's specific to a harm reduction agency, etc. Time's almost up. MSO link, provider convenings, come yell at us if you want. This is one of the places that you can come get some answers. And MSO, timeline, you can see that later. But pretty much, there's always money coming in and out. It's a hot mess. And then, yes, please stay connected. Hopefully, I have made this friendly enough. Please do stay in contact. We are far from perfect, but we are trying to be better. We are trying to improve communications and get better. We're building infrastructure. But yeah, we will listen. Thank you.
Thank you so much to Salkin for doing a great presentation and making it more understandable about the various funding sources. Salkin really is accessible and open to talking with you all about these different funding opportunities. We know we're at time. We still do have like a 10-minute presentation by CDPHE. If you have to step out, feel free to. And they will provide some really great information. The dinner's going to start at 5:30, so you still have a little bit of time. But we just want to be aware that we are at 5 o'clock right now. So we invite you to stay just for 10 minutes. They think they have just a couple of slides. And then we will have dinner at 5:30 with the AG. And if you have not registered for dinner, we invite you all to attend. So no worries, there's plenty of food for everyone.
On this, it says this goes to 5 minutes.
Oh,
Yeah. We're doing it perfectly. So I think.
oh my gosh. So we're on track.
Okay. We're on track?
Thank you.
Okay.
We're on track with that. We have some great speakers with CDPHE.
Okay, good. I was like, we got 10 minutes, we gotta go quick. All right. So my name's Andres. I manage the overdose prevention unit at the State Health Department. I am here with my colleague, Sophie. We're gonna talk about some opportunities from CDPHE, and I will just jump right into it. If you have any questions, please raise your hand as we're going through. One of the big ones is a coroner mini grant opportunity. So right now, CDPHE is supporting coroner toxicology testing. So that is an opportunity for coroners to be able to access funds to pay for toxicology testing. That helps the coroner, obviously, because that way they can do more tox testing. It also helps us as the State Health Department because we get a much better idea of what drugs are involved in overdose deaths, right? So this is how we're going to start to be able to pick up deaths associated with things like xylazine and some of those new, opioids and non-opioids that are popping up. So that is one. And we have something called a COSUP. And the COSUP is from the Bureau of Justice Assistance. I might regret this later, but if you have not looked into the Bureau of Justice Assistance as a possible funding source, it's really, really geared sometimes for rural areas, but always geared to get people from the criminal justice system over to looking at substance use as a medical behavioral health issue, right? So the whole intent of it is to move people away from the criminal justice system, which is very expensive, not very effective, and move them into somewhere where they can access treatment and care, right? And those are available both to us at the state level, but also to locals as well. And that usually comes out every year in the spring. So if you have not looked at that as a possible funding source, take a look. What we do with that funding is this last round, we've been supporting recovery support services, reentry case management, making sure that all of our law enforcement and first responders have access to naloxone and training, and then educating providers as well. So that's what we're doing with it. We will be applying for that again here. We've gotten, I think we're on our third round of funding from them, so we'll be looking at more funding and pushing that funding out the door as well in 2024. Overdose data action. This is CDC funding, right? So we are actually ending our current CDC funding cycle at the end of this month in just a couple of weeks. We are waiting to hear a notice of award for the next round of funding. The next round, they kept giving us 3 years, 3 years, 3 years. We kept telling them that's not enough time. 5 years this time, right? So they give us 5 years of funding, or they might, we'll find out in a minute. But if we get it, we will have some opportunities to be able to push a lot of this funding comes, from the feds to the state and then out the door, right? So this is the type of activities where if you're looking to fund prevention, if you're looking to fund stigma reduction, if you're looking to fund all these different things, evidence-based, data-driven prevention initiatives, then that's what this funding is for. If we get the funding, expect to see a couple of RFAs. One's going to be for linkage to care, and the other one's going to be for harm reduction. Those will probably be coming out. If we get our funding, we'll be able to push those RFAs hopefully out around November, December. This is the big one, naloxone bulk purchase fund, right? Is everyone aware that there's a whole lot of agencies that do not have to pay for naloxone? You can get it for free through the State Health Department. Yes, 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 yes. Is anyone not aware of that? Don't be embarrassed. Okay. Good. So there was a big expansion in the agencies that were eligible a couple of years ago. It started off with, first responders, law enforcement, harm reduction agencies. It's greatly expanded correctional facilities, private contact prisons, community corrections, pretrial services, probation, local public health, libraries, religious organizations, right? A lot of different entities can access free naloxone, and we greatly encourage you to access this funding. Right now, we actually have a lot of money for it, which is good. We don't always have a lot of money. There's been a couple of times in the past we've run out. What we'll do is we'll take the orders, we'll let folks know, like, hey, we're waiting for more funding, but we have your order, we'll process it in the order that it was received, right? But right now, we have plenty of funding. So if you know agencies, entities, organizations in your areas that are not accessing it and would like to, please reach out to us. We tried to make this as easily accessible as possible. So it is a Google form. We need your name, your agency type, your address, your phone number. That's really it. Yes, ma'am.
Can you say that? Are they required to do a training?
Yes.
For the public?
Yeah, so there's different ways that we can do the training. We only have 2 people right now working on this entire project, and it's kind of doubled in the last 10 months. So I'm about to hire another person actually very soon. We do a little bit of training, but a lot of that training actually goes to the consortium, and they're able to, in different parts of the state, either do the training themselves, or what we like to do is have them do train the trainer events so that we have more people that can do the training, right? The most common form of naloxone requested is the nasal. It's not difficult to use, right? What you're looking at as far as training is being able to recognize an opioid overdose and respond to that overdose. Right? There's also an app, Opie Rescue, free app. You can download it on your phone. That actually will walk you through the steps on how to respond to an overdose. Good question. Any other questions about this? So yeah, a lot of different agencies that are eligible for this now. We really want folks to reach out to us. Yes?
And each individual agency needs to have a standing order signed by a medical person, right?
Yes, but our medical person at CDPHE can sign that for you if you don't have one, right? So sometimes agencies either don't have access to a physician who's willing to sign it, or for whatever reason, they don't have it. So we have the capacity for our medical director to be able to sign that on your agency's behalf. So it's kind of a 2-step process. You need the standing order, and then you apply for the bulk fund. And the bulk fund, it's a little bit of a misnomer. What you do is you put an order in for naloxone to us, we send it to the wholesale pharmacy, and then they drop ship directly to you. So we do not have a giant warehouse of naloxone somewhere at CDPHE. We don't actually ship it from ours. We have them do it because they're much better at it, and that's what we pay them to do. Yes?
Just a quick question on the standing order. In some of our more rural communities, if there is a small organization that may only need 3 doses of naloxone, would you recommend that they go through this entire process in accessing the bulk fund, or would it be better if they partnered with another local nonprofit and let that nonprofit that's going to get, like for example, their public health department or their Western AHEC, I know Lindall, does that a lot.
Yeah.
And then for like those smaller orders, maybe work with a larger organization that's going to be purchasing larger bulk rather than going through the whole process.
It's going to be quicker that way, yes.
Okay.
Right. So yeah, then it definitely would be quicker if you're going to work with another agency that's able to access the naloxone, already accessing a lot of it. They can just give you some doses. That's fine. Some agencies do that, and then they realize, you know what, we have it here at the office in case somebody overdoses in our office. But what we really want to do is push that out to our community, so we need more. That's great. That's what we want you to do. If that's the case where you need more, just reach out to us and we can get you signed, your organization signed up directly, so you don't have to have that middleman. Any other questions? Harm Reduction Grant Program. We have 13 projects across the state implementing evidence-based harm reduction efforts. Funded programs include public awareness, education, law enforcement-assisted diversion, and harm reduction services for people who use drugs, right? So this is a great opportunity for organizations, especially for parts of the state where we don't have enough harm reduction services, right? Which is a lot of the state. A lot of that is really focused around the metro area. So if that's something you need and you're like, hey, we want to do this, we finally were able to gather enough public support, to really make this happen in this area, but we don't have the funding, this is an opportunity, all right? I just saw 5 minutes, so. Any questions about this? There you go. I'll pass it off to Sophie. Thank you. What is this?
Hi, everybody. My name is Sophie Feffer. I use she, her pronouns. I am the Drug User Health Coordinator in STI, HIV, and Viral Hepatitis' Office of Syndemic, of the Syndemic team. A lot of words there. Let's break them down. So STI, HIV, Viral Hepatitis, I'm coming at you all from a really different perspective. I come from an infectious disease approach. Why is this relevant to the overdose crisis? Because the folks who are at highest risk of death from HIV, viral hepatitis, and STIs also use drugs and are also at the highest risk of overdose death. So we have to do all of this together in order to best meet the needs of our communities. What does syndemic mean? Exactly what I just said. Approaching everything at once and realizing that two separate health issues need to be approached together in order to solve them, right? Or to provide solutions. Last but not least, what the heck does my title mean? It's very broad. I provide support to people who use drugs and the folks that serve them. That's everybody from a local health department to a ROAC to your local syringe exchange program. I don't care who you are. If you work with people who use drugs, I want to support you. So in terms of financial support and capacity building, my office has an STI, HIV, viral hepatitis training unit. We host both in-person and asynchronous trainings for all things infectious disease. At the end of the day, I'm mentioning this because these are free resources that can be shared with folks who are newer to working with people who use drugs, who are newer to working with folks who struggle with opioid use disorder and need a little bit more cultural competency training, right? So what does it look like to work with an LGBTQ plus individual? What about someone who uses drugs? What about, what if I want to implement HIV testing? We have trainings for all of those things. They are free, they are open to the public. And they are always presented by subject matter experts, myself and my colleagues, who will always be open to having those additional conversations around training, around technical assistance. I'm going to pull a little bit from Salkin here, because when we say braided funding, it is very braided. And we pull state opioid response dollars from the BHA, specifically to support our harm reduction programs. Those fall into two main buckets for us. I'm going to start at the bottom. We braid some of our SOAR funding in addition to CHAP dollars, which I'll talk about next, as well as our CDC funds that we receive for HIV prevention to support Colorado's 21 syringe access programs with direct funding for supplies distribution and technical assistance. In terms of what I can do for you all today, I am the test strip lady. I love fentanyl test strips. I brought them with me and I don't want to leave with any, and I mean that. So thank you, Andres. So right now we have two different fentanyl test strip programs. The state opioid response dollars are used to buy no-cost fentanyl test strips and soon xylazine test strips, which is very exciting, for all of Colorado's syringe access programs. We have separate funds from House Bill 1326, which is the Fentanyl Prevent and Accountability Bill, that is specifically currently for local public health departments. Is anyone in this room work for an LPHA who orders test strips from me? Does anyone work in an LPHA does not yet order test strips from me? Ooh, cool, I love people being in my inbox. Awesome, I would love to fill those gaps. Right now, this number is actually wrong. I think we have 23, I'm actually up to 33, which is over 50% of Colorado's health departments. I'd love to get higher than that. I also am very close to expanding this program specifically to support rural communities who do not have broad access through a health department setting, right? Like DDPHE's got that whole clinic available. We don't have that across the state of Colorado. So how can we target that distribution specifically to rural communities to ensure that we're also pairing Andres' naloxone bulk fund with the fentanyl testing strips, because they should always be together, right? I already mentioned this. You might be familiar with the acronym CHAP. It's the Colorado HIV/AIDS Prevention Grant Program. The reason that I'm bringing HIV prevention in this conversation is historically this is going to be the largest and most accessible funding for syringe access programs within the state of Colorado. We have 21 legal and operating sites. They are run by 15 different agencies within the state of Colorado. This is specific to folks who are vulnerable to acquiring HIV. Obviously, people who inject drugs are included on that list. We're being syndemic, and that's why it's related to opiate abatement. The CHAP dollars fund a couple different things. I'm going to start at the bottom. We do FTE support and supplies distribution for all of our syringe access programs. We fund case management specific to people who inject drugs. We actually have one of our grantees in the room right now. Georgia does an incredible job with her team at Boulder County Public Health for case management for people who use drugs and folks who are leaving incarceration, big snaps. We do marketing, education, and outreach. That could be everything from literally backpacks on, going out into the community, meeting folks where they're at, to maybe we're talking about social media campaigns, making folks aware of our services. And then last but not least, we do sterile syringe procurement. That means that I purchase all of the syringes for all the legal syringe access programs in the state. As you may or may not know, there is a federal block on funding for syringes, so we're trying to strategically use those dollars in an extremely effective way to prevent HIV, create more contacts with people who use drugs, connect them with testing, connect them with overdose prevention, connect them with treatment, and ultimately prevent that initial spread of infectious disease. That's it for us. Our emails are here at the bottom, but it looks like I've got a question from Stephanie.
Yes, Sophie, when do you anticipate that the xylazine testing strips will be available?
So that's a really good question. I am in the paper pushing phase of my xylazine test strips, but I'm very, very close. What we do know is that there are already some available across the state of Colorado. Folks are able to use those CHAP dollars. So if you're a syringe access program and you're a recipient of those funds, you're able to leverage those tax dollars, or pardon me, CHAP dollars, which are tax dollars, I digress, to purchase xylazine test strips in addition to the some other more flexible funding within the state. So we do have some accessibility, specifically through our syringe access programs, but I am hoping before the end of this month, fingers crossed, to be able to roll out accessibility specifically for syringe access programs. And then in terms of wider than that, I'm always looking to broaden my scope. So it'll be narrow for the time being, and then we will work as hard as we can to make sure that that eligibility widens to meet the demand across the state. Any other questions? Oh, sure.
For folks who aren't familiar with what xylazine is, can you just briefly explain what xylazine is and why it's important to have these test strips? I don't think I've heard.
Happy to touch on that. I'll be honest, it's a beast, so I'll do my best. So xylazine is a increasingly frequent adulterant within Colorado's drug supply. We are seeing it consistently in places like the Northeast part of the United States. Places like Philadelphia have 80% plus of their opioids testing positive for the presence of xylazine. We're not there yet, but we have a very unique opportunity to get ahead of that proliferation so that while it's becoming more frequent in our drug supply, folks are able to do things like test their drug for the presence of xylazine. It works exactly the same as these fentanyl testing strips. Xylazine is a veterinary sedative. It is similar compared to ketamine often. What's interesting is that xylazine is not FDA approved for use in humans within the United States. As a result, we do not have a lot of knowledge around how this substance interacts with the human body, and we are seeing things like wounds and concerns in terms of heavy sedation and adding to that respiratory depression that we see really commonly in an opiate overdose, right? So I don't want to get too in the weeds. It's a little bit complicated. However, I do have a robust xylazine resource folder that is open to the public. If you would like to email me, I will share it with anyone who reaches out. So happy to do that. Salkin?
And the consortium did a great webinar too.
And I believe that was provider focused, correct?
Yeah,
Thank you.
Provider focused, but a lot of our provider focused trainings, especially that are recorded, are a wealth of knowledge for any lay person as well. We also have a webpage on our website that touches on the top line information about xylazine, and any one of us for external relations strategists can always set you up with a personal training for your region, for your community. You would just need to know in advance what you're looking for, and we'd be happy to help provide that additional information for you.
And I should add in Andres' team's landing page on CDPHE's website, so the Overdose Prevention Unit website, we do have a kind of really great 101 explainer of xylazine, as well as some great resources for all folks, whether you're a health department, a direct service provider, or someone who uses drugs.
I think it's just really important to know it does not respond to naloxone. So
It's not an opiate. So it's not that it doesn't respond to naloxone, it's actually just, it's not an opiate. It is almost only sold alongside other opiates. So the language here is always, always, always use naloxone. We already know that, right? The concern is that heavy sedation, once the naloxone has been administered, that individual might start to breathe again, but might continue to be sedated. That's really different for us. We have not seen that, right? It's very scary. So it's going to take some additional education, but we have the tools, and we are working diligently to share that information as much as we can. But I want to be transparent. This is new, and we are all learning. So we are doing our best to share that information as much as we can. Sure?
I know time is up. This is another question from a Zoom person. How do we create access to testing strips for folks who do not feel comfortable going to health departments?
Email me, because I would love to connect with your local community behavioral health organization, whoever it might be, in order to make those available. I'm not sure what community that question comes from, but in different regions we have varying accessibility. For example, of course, along the Front Range, we have more robust accessibility. You're going to find that in bars, at rec centers, places like that. However, as we've expanded into LPHA distribution, you're also able to find those through other community-based organizations, through libraries, at mental health service providers, homeless service providers. So it's growing and it's getting larger. And I should also note that while I might have the most robust distribution, I'm not the only funding or source of distribution for fentanyl testing strips within the state. Salkin?
Yeah, also our peers I mentioned earlier, there is a directory for them. They are funded to carry fentanyl and test strips as well, so they can do the onesie twosies hands out as needed, so please tap into those resources as well.
Real quick, is there still only about a handful of states, like a dozen or so, that are actively in legislation making xylazine a controlled substance? And is Colorado still not one of those?
I can't speak on legislation. My apologies.
The DEA said this morning that Colorado is not.
Yeah, they're not. I know the federal is also going, but they're slow. So a lot of states are going on their own path to.
It's a normal path, right, in terms of our systems and how we respond to adulterants in our drug supply. Unfortunately, I'm unable to speak on legislative stuff, state entity stuff, you know. Any other questions? I mean it. I have like 600 test strips. Please take them from me. If you have an agency, someone you want to share them with, I've got business cards, and thanks for your time.
And can we just give Sophie and Guerrero now ready for dinner, and so you guys want to set to the board. There's a range of foods to choose from. So thank you, everyone. Okay, now we have the fun part of the evening.
I'll check it out.